Hello everyone. I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will study an important topic of erythema multiforme. Okay, and from this you will be getting a short note. Just look at this image very carefully because this image only helps us to identify that it is a case of erythema multiforme. Okay. Let's talk about the definition. So it is acute immune-mediated mucocutaneous disorder characterized by a target iris lesion. See this basically, it is looking like a target, right? So it is a target lesions. If I talk about the epidemiology, it is common in children and young adults. Male is predominant, and there is recurrent infections that can be there. If I talk about the classification, then you have the major one, the minor one, and the distinct forms. Okay. In the minor one, there will be target lesions, little or not involving the mucosa. In the major one, there will be target lesions plus the mucous membrane is involved. Let's talk about the minor one. So in the minor one, you have the target lesions on the extremities that are there. Usually they are self-limiting and often they are due to post-infection, especially like the HSV. Then in the major one, there is target lesions, one or more. It can involve the mucous membrane or it cannot involve the mucous membrane, right? Then you have the oral, ocular, genital involvement is there. Oral, ocular and genital involvement you will be able to appreciate. Okay, it is more severe than the minor one, obviously, because it is the major one. It has to be more severe than the minor one, right? And it involves more one or more mucous membrane. That is why also it is very serious, right? And it also has the presence of target lesions. Then you have the triggers. The triggers are HSV. That is the most common trigger. It is one of the most common trigger, and HSV1 is more than HSV2, right? Then trigger number 2 is your mycoplasma, particularly in children associated with predominant mucosal lesions. Trigger number 3 are your drugs like your sulfonamides and anticonvulsants and NSAIDs, right? Then other triggers are your other infections like the 𝗖𝗵𝗵𝗴𝗿𝗺 and the hepatitis and the 𝗘𝗵𝗵𝗴𝗺. If I talk about the pathogenesis, what happens is there is HSV DNA or protein in the skin. It activates the CD8 cytotoxic, and as a result of which the T cells will respond, and there is keratinocyte apoptosis that will lead to the target lesions, right? If I talk about the pathogenesis of drug-induced one, there will be immune-mediated keratinocyte necrosis, which will lead to the progression of SJF. If I talk about the immunology one, there is CD8 and T cell cytotoxicity that you will be able to appreciate. And after that, there is keratinocyte apoptosis. So, are you able to appreciate one thing? That keratinocyte apoptosis is seen in each and every stage, right? Keratinocyte apoptosis is seen in each and every stage. And there is type 4 hypersensitivity. If I talk about the clinical features, then it has target iris-like lesions with 3 concentric zones, the symmetric and aslap distribution. If I talk about the clinical features, then the mucosa in minor is little involved, and in major you have the oral mucosa, ocular and the genital erosions will be there. If I talk about the clinical features, the person will be having mild fever, and with fever you will be having malaise. There will be severe systemic illness, and you have to consider that it is a case of SJS. The course, if I talk about, acute will resolve in 1 to 3 weeks, and recurrent is more common in HSV cases. Histopathology, interference of dermatitis with basal keratinocyte necrosis. Okay. Next is what are the investigations? See, it is mainly clinically diagnosed because you are able to appreciate that very pretty lesion, right? So you are able to diagnose it clinically, right? History will give you a clue. Investigations, PCR you will do, or serology if recurrent HSV is suspected, right? Then biopsy to confirm the interference and to exclude the dermatosis. You also have another conditions of dermatosis. To exclude the conditions that we are not dealing with the case of dermatosis, you have to do a biopsy. Then you have to take a drug history very in detail, right? That I know you have been taught history taking very clearly, right? Differential diagnosis will be it is SJS. is drug induced and systemic toxicity is involved. Then why it's not a fixed drug eruption? Because in fixed drug eruption, you recurrence at the same time and you are having solitary or few round lesions. Others differential diagnosis can be the differential diagnosis of urticaria, erythema multiforme, and bullous disorders. What is the management? You have to identify and remove the triggers. You have to give the supportive care to the patient. Hydration and wound care should be there. In the management, you will give the acute antiviral therapy. Then there will be long-term prophylaxis in recurrent HSV associated with the erythema multiforme. In the management of the symptomic, you have to give the topical corticosteroid, antihistamines should be given, and topical steroid mouthwash for if the person is having the oral lesions, then you have to give the mouthwash as well to the patients. Okay. Next is if there is a severe case or refractory cases there, then you have to give the immunomodulators like azithromycin and cyclosporin. Dapsons you can also give, and rest you can consult your dermatologist. If the patient is having SJS, then the management that you have to do is the immediate drug withdrawal, then ICU or admit the patient to the ICU or the burn unit. Then you have to give the systemic support as needed by the patient. What are the other complications that can occur? First one, there can be conjunctivitis, corneal ulceration, and scarring can be there. There is potential permanent vision loss. Okay. What are the other complications? There will be painful erosions, dehydration, and nutrition if compromised to the patients. Other complications, there can be bacterial infections or the erosions that the person can have. Prognosis, see, minor one is self-limited and it resolves around 1 to 3 weeks. Major one is more morbidity due to the mucosal involvement. Hospitalization may be needed. Hospitalization may be needed in the cases of major one, but if we are dealing with the case of the minor one, then hospitalization is not at all needed because minor one can resolve within a particular given amount of time, right? If I talk about the recurrent one, then HSV prophylaxis to reduce the recurrence. So these are basically the things that we have read. See, from this you will be getting a short note. So just prepare this topic in that manner. Remember this beautiful diagram of your target lesions, and if in your question it is asked, draw this diagram. Okay, this target lesion. You have to draw this diagram. Okay. You can't go to the examination hall without even knowing this topic. Okay, remember that there is something called as the target lesions that are present over here. We are sorted with this chapter. If you are having any sort of doubt, please feel free to ask me. Please feel free to reach out to me. Thank you so much.